From the JAMA Network, this is JAMA Oncology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Oncology.
Hello and welcome to our listeners around the world. You are listening to JAMA Oncology Author Interviews. Thanks for joining us. I'm Vivek Subbiah, medical oncologist, Chief of Early Phase Drug Development at the Sarah Cannon Research Institute, Nashville, Tennessee. And I'm also the JAMA Oncology podcast host for today and the web editor for JAMA Oncology. Today, we are diving into a groundbreaking clinical trial that addresses one of the most distressing challenges in palliative care, delirium. Joining us are Dr. David Hui and Dr. Eduardo Bruera from the University of Texas MD Anderson Cancer Center, lead authors of the recently published study titled Proportional Sedation for Persistent Agitated Delirium in Palliative Care, a double-blind, placebo-controlled, randomized clinical trial. This multi-center trial is the first of its kind to rigorously compare scheduled haloperidol, lorazepam, their combination, and placebo in patients with advanced cancer experiencing refractory agitation. Dr. Hui and Dr. Bruera, it's a pleasure and honor having you on the podcast. David, can you please introduce yourself?
Thank you, Dr. Subbiah. I'm David Hui from the University of Texas MD Anderson Cancer Center. I'm currently a professor in the Department of Palliative Care, Rehabilitation, and Integrative Medicine. Thank you for the opportunity to be here today.
Thank you so much, David. Dr. Bruera, can you please introduce yourself?
Thank you very much, Dr. Subbiah. My name is Eduardo Bruera. I'm the chair of the Department of Palliative Rehabilitation and Integrative Medicine, also at the University of Texas MD Anderson Cancer Center.
Thank you so much, David and Eduardo. Today, Dr. Hui and Dr. Bruera and their team's findings offer insights into how we can personalize sedation strategies ranging from light to heavy to improve comfort and reduce distress in the final days of life. Whether you're a clinician, researcher, or a caregiver, this conversation, I hope, will shed light on how evidence-based sedation can be both compassionate and precise. Before we go on research-specific questions on the paper, Dr. Bruera, I would like to ask you a broad question for the broad listeners of JAMA Oncology. What is delirium at the end of life, and how does it differ from other types of delirium?
Thank you so much, Dr. Subbiah, for bringing this very important question and very important problem that all of us dealing with patients with cancer have to face frequently. It is a syndrome of essentially progressive global brain failure that happens in up to 90% of our cancer patients before the end of life. And it can happen anywhere from hours to weeks before the end of life. And so it's a very frequent and enormously distressing syndrome, not only for the patient at the early stages, but also for the family and the clinicians taking care of them.
Thank you so much. So, David, what motivated the design of this record study? So I love the name record because the design of the rotation, escalation, combination, or reduction for delirium study, particularly the inclusion of both haloperidol and lorazepam arms, and how did clinical equipoise shape your decision to include a placebo group here?
I would just start by saying what inspired this study, the patients, who are going through this very close to the end of life and seeing the amount of suffering in our patient population and the caregivers, and recognizing we need to do a better job to support them during this time when it is having the restlessness and can't communicate. That causes a lot of difficulty even for caregivers to spend the time with them. I think the other reason for doing this study is because of the gap in knowledge. In our field, we need, more studies to help us to understand how do we use medicines to support our patients. There's been a tremendous amount of debate whether haloperidol helps patients at all, or is it harmful, as well as the role of benzodiazepines, which there's been a lot of concern about as well. So I think only through having a well-designed study can we attempt to answer these kind of difficult questions. And to the point of introducing a placebo, that is certainly something we think about a lot. we have previously conducted studies without placebo group, but after a lot of discussion and thoughts, it was felt that having a placebo is the main way to allow us to truly understand if the medications are better than if they're not used. And especially given there has been a lot of doubts raised regarding the efficacy of medicines, we feel that it is justified clinically, and I think our IRB agrees as well.
Thank you so much, David. So your findings suggested that lorazepam alone or in combination with haloperidol was more effective than haloperidol alone. So how do you interpret this in light of previous concerns about benzodiazepines potentially worsening delirium?
I would say this is where the primary focus of the study and the population we are studying is particularly important. We are really looking at patients with end-of-life delirium who often have days to live and with persistent agitation despite standard measures. And so in this situation, the goal may not be to further reduce delirium, but more to palliate and provide comfort. And this is why I think some medication to reduce that restlessness for patients and the families can see that can be very hopeful. So that's why our primary outcome is the RASS score, which assesses the level of sedation. And we feel that would be a reasonable way to assess how good these medicines are in reducing the agitation. And our key secondary endpoint is the use of rescue medications, which is really an indicator for what we call breakthrough restlessness. Just remember that every time we need to use a rescue medicine is a failure, of us being able to support the patient. So they become more restless again and need something. And when we are looking at people with days or hours to live, every second counts. So it is even so much more important to ensure our patients are supported adequately with the proper medication. And ultimately, it's a balance between oversedation and undertreatment, leading to more distress.
Thank you so much. Now on to Eduardo. So the study introduces the concept of proportional sedation with light, moderate, and heavy options. So how do you envision clinicians applying this framework in real-time decision-making at the bedside?
Thank you very much, Vivek. This is a hugely important question because we now understand that the term delirium encompasses a large number of separate syndromes, and patients might present in a radically different way. Some patients who are profoundly agitated with delusions, hallucinations, psychomotor agitation might, after that episode, become quite oriented and attentive. And many other patients, after that episode subsides, might remain profoundly confused and inattentive. And therefore, efforts to decrease the level of unnecessary sedation in the first group might be highly appreciated by their families and by the clinicians, while in the second group, that is the patients who have that enormous amount of persistent confusion and inattentiveness after the episode of agitation subsides, might benefit from that much less. So I think we're learning the value of a highly personalized approach to both the efforts we make to resolve an episode of delirium and also the efforts we make to reduce the agitation when that becomes impossible, as it is in this case.
Thank you so much. So the next question to Dr. Hui. So given the study's limitations, such as its focus on end-of-life delirium and intravenous administration, what are the next steps in research to broaden the applicability of your findings?
I do feel this study's findings should be limited to patients who are under the care of palliative care, particularly specialized palliative care teams. And we are really looking at people with refractory delirium and agitation. So I think to me, the natural next step would be maybe going beyond, patients with cancer and other patients who may be having other conditions, but also very close to the end of life. I would imagine the findings may potentially be further studied. And I think in terms of earlier stage of delirium, unfortunately, patients can still develop restlessness and hyperactive delirium as well. But we would be very cautious how we use this medication in that setting for the very concerns that you mentioned, that benzodiazepines may worsen it or cause oversedation. I think only through very careful research, can we figure out the best way. There may be other medications in other settings that may be more appropriate. And I think this is just the first step in understanding how we can manage this very challenging syndrome.
Thank you so much. The paper mentions that perceived patient comfort was significantly higher in the lorazepam and combination groups. So, Eduardo, how do you think and how important is caregiver and nurse perception in evaluating treatment success in such palliative care trials?
Thank you, Vivek. That's a hugely important issue. Many years ago, we conducted some research exactly on this particular area. That is, the recall of having had delirium and hallucinations. And we looked at physicians, nurses, and bedside caregivers. And we found that first of all, 74% of the patients who recovered from an episode of delirium remember having been delirious. And those who remembered were much more distressed. But we also learned that the closest estimation of the presence of delirium and the presence of delirium-related behaviors came from the bedside family member, superior to the nurse, superior to the physicians, perhaps because of their continuous presence and the naturally fluctuating level of delirium, so that episodic entrance of a nurse or the physician might not capture so well is the difference between an EKG and a Holter. The family member is a Holter and the visitor, us, is more of an EKG, and therefore taking advantage in research of methods that provide a kind of an observational Holter. And also the presence of the bedside family member is important, not only in research, but also in clinical care. Making them part of the care team when the patient has delirium is a wonderful way of learning what they observe, but also making them feel listened to and cared for.
Thank you so much. So once again, coming back to you, Eduardo, what advice would you give clinicians who are hesitant to use scheduled sedatives due to concerns about oversedation or loss of communication capacity in dying patients?
This is a hugely important point, Vivek, because in reality, it is quite appropriate that if you're facing a patient whose cognition is starting to fail and who are starting to present aspects of what the psychiatrists call positive symptoms, that is, delusions, hallucinations, psychomotor agitation, hostility, disinhibition, neuroleptics are a wonderful way to try to reverse some of those. But when those are persistent, as in the case of this study, at that point, we do need to help that patient, as David so nicely was proposing, help those clinicians too. And if you feel unsafe, please consult your supportive care and palliative care team. Put a consult to them, and they will conduct an assessment, see what else is there that you might be missing, what drug interactions, what else is happening to that patient that might be potentially reversible or helped. And if not, help decide that that's the right pathway for that particular patient. It is understandable what you're saying so well, Vivek, that this is a distressing time for the clinician also, and therefore take advantage of those people who can go to the bedside and give you a hand.
David, what are the next steps in your research?
With research, I think it opens up more opportunity. One particular issue we are very interested in is to learn about how we can further, based on the findings, personalize how we support our patients. So we're asking the caregivers a personalized sedation goal and trying to find the most effective ways to meet those goals. So I think this concept of reaching out and getting the caregiver involvement is an important aspect. And I think we need to find better treatments as well. I think these medications are pretty blunt instruments, and only through good clinical trials and collaboration with others can we move the field forward.
Thank you so much. So, Dr. Bruera, any key takeaways and final closing thoughts for our JAMA audience?
I think what we would like to encourage is that the same as we have the tremendous talent of the Vivek Subbiahs in this world that help us find new pathways to work on very specific problems and improve outcomes, but also reduce side effects, toxicity, suffering for our patients and families. With regards to cancer care, it is so crucial that we develop the new generation of David Hueys, the people who can really look at other phenotypical and markers aspects of the suffering experience, so that combining those, we can really make a big difference in the way end of life happens to 100% of us into the next generation. So taking advantage of the kindness of Vivek and JAMA Oncology to promote this type of work, hopefully will inspire leaders who are listening to this to say, do I have this type of researcher in my program? And if I don't, maybe I should get myself one.
Thank you so much, Dr. Bruera. David, any final closing thoughts?
Yeah, thank you, Vivek. I think this is a very difficult study to do, but we are glad we're able to complete it. And the findings suggest that medications may have a role to support our patients, and being more proactive, supporting our patients may be able to alleviate some of the suffering. And I really want to also take this opportunity to thank the patients who are on the study, the caregivers who agreed to enroll their loved ones on the study, and the palliative care unit staff from MD Anderson, Virginia Commonwealth University, as well as National Taiwan University for their dedication to support this study as well. I think through their commitment, we show that even in the most distressing and difficult situations, we can do research to answer some clinically relevant topics and hopefully further the evidence further. And we also like to thank our funding agency, NCI, for their support for this trial as well.
I'm Vivek Subbiah, and I've been speaking with Dr. David Huey and Dr. Eduardo Bruera about proportional sedation for persistent agitated delirium in palliative care, a double-blind, placebo-controlled, randomized clinical trial that has been published in JAMA Oncology. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.